Welcome back to our roundtable discussion. We're now going to explore practical approaches to current care of newly diagnosed multiple myeloma. We have a number of regimens listed for patients with newly diagnosed myeloma in NCCN guidelines. We're going to ask our panel how they themselves utilize some of these regimens in their own practice. But before we do so, I would like to see, for those who are transplant eligible, is there anybody that you would not recommend going down the transplant road today? So again, this time I'll go ahead and start with Ajay. So what is your take on the role of transplant today?
So we have always been believers of transplant, as we've shown long-term data, even with the 3-drug regimens. The transplant deepens the response, and we've been able to show that this improves the overall survival. When we translate this to a quadruplet therapy, we have clearly shown the exact same thing. By deepening the response, you're gaining those MRD negative rates, and you can get to translate this into a PFS and an overall survival benefit eventually. So how are we using the existing data to prove that point? If you compare the quadruplet regimens with Perseus, with IMROZ and Benefit, those are prospective randomized trials. So you're seeing those CR rates almost increase by 20% in the transplant eligible patients, even with a quadruplet regimen upfront. So those are the data that clearly tell us like transplant offers us that benefit of increasing those depths of responses by almost 20%. And that makes me feel that transplant should continue to be offered for every transplant eligible patient.
So I guess, is there anybody who has a different view on this? For transplant eligible patients, that transplant as part of initial therapy should be considered for every patient. Anybody seek to differ from that?
I would differ a little bit from Ajay. A young patient who is standard risk, in my practice, I don't necessarily push for transplant. This is obviously different recommendation from a relatively older patient, such as a 74 or 72-year-old patient who is approaching that age where we would never take that patient to transplant. In that case, if a patient is interested, I would definitely proceed with transplant upfront. But a younger patient, I could give time, but it is something like a transplant deferral strategy rather than complete omission of transplant for all the reasons that Ajay indicated regarding the value of transplant.
Okay. So we've talked about in our first segment, the induction regimen. So I think we will at this time talk more about broadly what the goals of therapy are for our patients. So Sasha, what is your goal of therapy for frontline patients today? Is there a certain depth of response you're seeking to achieve? And what is the role in your practice of consolidation in a transplant eligible patient?
So I don't routinely do consolidation, and so I think it's important to highlight the fact that we know that depth of response predicts outcomes, but we have very few data to suggest that doing things differently to further deepen response actually improves outcomes in patients with suboptimal responses. And so with that in mind, especially when we think about what we're putting transplant patients through, where they get DRVD and then they get stem cell transplant, they've already had most of our effective drugs. And so to pull other things out of our pockets, such as other agents, carfilzomib or pomalidomide, other agents to try to deepen response, I don't think makes a whole lot of sense. We don't have a lot of data for it. And again, post-transplant consolidation, I think, is very reasonable to try to deepen response, but we have the stamina study, which suggested that there wasn't much of a benefit to that, at least when applied to all patients. And so to summarize, I'd say that I think consolidation is an interesting idea, but we don't have a lot of data to suggest that it's beneficial, even for patients with suboptimal responses. So I don't routinely do it.
John, what do you do in your practice?
I think along those lines, patients with suboptimal response, I follow them more closely. And if there's any reasons to change treatments, I do. But I don't add new classes of drugs or new treatments outside of clinical trials just to try to get a deeper level of response. That said, I guess the goal of treatment would be to use our optimal approaches for drugs, plus or minus transplant and maintenance to get the deepest level of response. But I don't think we have data to change treatments, add treatments to get to that point in the current state.
Ajay, what's your goal, and do you use consolidation?
So I typically don't choose consolidation. So maintenance is a misnomer. So maintenance continues to deepen the response. So the biggest question that comes into us is like achieving an MRD at 6 months versus achieving an MRD at 1 year. Does it really have an impact on the long-term outcomes? So achieving an MRD early, if it makes an impact on the long-term outcomes, I would be more than happy to use that consolidation, but we don't have that data available. So that's what makes me believe that the maintenance itself deepens the response over a prolonged period. And I don't use any other novel agents or alternate agents to achieve the depth of response.
Melissa, what's your practice?
Yeah, so I mean, I think there's enough evidence that achieving MRD negativity is important and is correlated with better survival and better progression-free survival. So that is the goal, my goal of therapy. Obviously, if a patient is a standard risk patient, and then there's also data to say that patients, for example, that are less than CR 3 months post-transplant fare worse, right? That patients that are in CR. So I think once we lose that first response, that makes a big impact on the patient outcome and progression-free survival and overall survival. So I make I would do everything I can, especially in high-risk patients, to try not to lose that first response, right? And again, it depends on the patient that I have in front of me. It's not a one-size-fits-all. It depends on the patient, the disease characteristics, the patient characteristics, and based on that, I decide. But if a patient is in CR and MRD positive 3 months post-transplant, I probably would do Revlimid data for maintenance. I would not do necessarily consolidation. But if a patient is a high-risk patient that is less than CR, I would try to do more treatment to get them there.
Prashant?
I would also agree with everything that's been said about not having good evidence or great evidence regarding the role of consolidation, but it has been adopted specifically for the high-risk patient population where there is at least to some degree, people are ready to accept higher risk associated with the use of consolidation in terms of the toxicities associated with it. I personally use some degree of consolidation only in patients with high-risk disease, but definitely remove dexamethasone from the consolidation phase pretty quickly and get down to the agents such as bortezomib and lenalidomide or carfilzomib and lenalidomide based on the Forte data and just continue until progression in the high-risk patients.
I know you all have sort of hinted throughout the program on high-risk patients, but just to have a pointed question in that regard, Sham, how do you use risk stratification in your plan for frontline therapy? Just a broad, question. I know it defies a simple answer, but how do you use it?
So I think the most important information that I get from high-risk status is just that the patients that have markers of high risk needs to be followed more closely than others. They can relapse quickly, they can relapse very aggressively. So I think even when they're doing well, I tend to keep a pretty close watch on those patients with close follow-up, because I think if they're likely to progress, they're likely to progress quickly, and therefore would need a change of treatments at short notice. So that's probably the most important thing. Now, do I make sweeping changes to my treatment plans based on high-risk status alone? Not yet. As we've discussed now, high risk or not, everybody gets 4 drugs if they can tolerate it, I think, for induction, if they're transplant eligible, etc. So that part is similar. I don't tend to use carfilzomib preferentially to high risk necessarily, at least not yet in the frontline setting, but some groups and doctors do. That's one change, I guess. I may be more inclined to recommend doing upfront transplant for patients who are high risk for that reason. So maybe that's another area where risk status plays into this discussion. So I'm less likely to be inclined to do deferred transplant in the high-risk population. And then with maintenance, I think we've already discussed 1 drug, 2 drug, 3 drugs for maintenance. Perhaps there's no. But I would caveat all of this by saying that this is mostly based on our interpretation of subgroups of trials and his retrospective data. We lack prospective data in high-risk population that's randomized or high-quality data. So I think we can all have strong opinions of how to do this, but they are at the end of the day mostly based on our interpretation of incomplete data.
Melissa, what's your take on high risk and how do you manage it any differently?
Not to select induction therapy. I agree with everyone that everyone should get 4 drugs, the quadruplet, but I use it to inform me later on, depending on how patient is responding, how aggressive I have to be if the patient has not achieved SDR and so on, but not to select the initial therapy.
Prashant, do you treat your high-risk patients any different?
No, I start off with the quadruplet. Perhaps in most patients, if they are able to tolerate, I go with carfilzomib as opposed to bortezomib. But again, as Sham has already alluded to, there isn't very good data to support one quadruplet over the other, and we truly need such studies. Outside of that, as has already been discussed, I do recommend upfront transplant, given the value of achieving as deep a remission as possible, specifically for the high-risk patient population. So go with transplant if a patient is transplant eligible, and then with a doublet, at least a doublet maintenance.
Sasha?
So I think Prashant just summarized what I would say. The only thing I would say is I don't routinely use carfilzomib, but fully agree with trying to get as many of those patients as transplant as possible, and then some sort of multi-agent maintenance. But otherwise, I second what Prashant said.
Ajay, you have the last word.
So I think there are 2 studies that I focus on. One is the GMMG concept study. This is a German study who used the 4 drugs, isatuximab plus KRD, carfilzomib and dex, and they gave continuously for patients who are transplant ineligible. And for transplant eligible patients, they're able to get a transplant sandwiched in between. So what they presented at IMS last month was a 4-year PFS of close to 60%. And these are high-risk patients. Even among the transplant ineligible patients, you're able to maintain those responses, prevent those progressions from happening. You take the same example to master trial. So these patients are high-risk patients. What Luciano Costa and the colleagues did was they stopped off maintenance based on achievement of an MRD negativity at frequent intervals. So if patients achieved sustained MRD, they have the option to come off. The group that have done so well are the standard risk patients. At the 6 years that they presented at IMS, 95% of the patients still continue to be in remission. Make a guess of these ultra high-risk patients who have more than 2 high-risk features, 28% of the people were progression-free at 6-year mark. So clearly, one thing that we can take from both of these high-risk patients, you can't stop maintenance. You have to give a combination maintenance for as long as you can prevent the progression.
One of the things that is important for our community physicians to understand is that the doses that are studied in clinical trials may not be applicable to the general population. So how do you modify dosing for your transplant eligible and ineligible patients?
So I think that that's a very important point, and that as we've seen in many of the studies that have gotten these regimens approved, they often use twice weekly bortezomib is probably the big one. Or I think, there's now data going back more than 10 years showing us that once weekly bortezomib works as well as twice weekly in terms of efficacy, manifest as depth of remission or depth of response, as well as duration of response. But we see a whole lot less toxicity, so primarily less neuropathy as well as GI toxicity. And so one pearl that I would say is that we almost always do once weekly bortezomib, not twice weekly bortezomib, probably at the dose of 1.5 milligrams per meter squared. And the exact way to do this in the ideal world is not exactly established, but for what it's worth, I usually do the 1.5 milligrams per meter squared days 1, 8, and 15 on a 28-day cycle.
So, Jay, what do you do differently than in clinical trials?
I think one of the centers probably is ours, like where we use the twice weekly dosing for the transplant eligible patient populations, similar to what we saw in the Griffin trial, Perseus trial. So this is a condensed three-week cycle where patients would receive doses of 1, 4, 8, 11. So the nuances all come in the transplant ineligible patient population. So the MRAS trial used twice weekly dosing for the induction period, which we don't use. We use the RVD Lite that was Betsy O'Donnell's data, and we extrapolate that by using combination of daratumumab or isatuximab. So now coming to the high-risk patients, so I I want to give more intense bortezomib if they're tolerable, even if they're transplant ineligible. So those are the nuances. And the one thing that I really want to focus on is the benefit trial, which used bortezomib for close to 18 months. And we never use that for 18 months. Like we typically limit off all the bortezomib dosing to the first 6 months, take off the dexamethasone probably within the first year. So that will allow for the effective drugs to be continued for a longer period.
Sham?
I mean, just to change to different drugs, I guess even things like carfilzomib, for instance, there are many different dosing schedules that have been studied, twice weekly dosing, 2027, 2036, 2050 or 45, 50s. I think many of us now use once weekly dosing for carfilzomib for ease and other factors. So just to be mindful, and I wouldn't say that every patient needs to get the exact same dose. As Ajay said, there are nuances. But regardless of whether you start once weekly or twice weekly, to be mindful that there's opportunities to dose reduce for toxicities. I wouldn't wait for severe neuropathy, for instance, to set in before dose reducing bortezomib. Similarly, if patients are having a lot of issues with fluid retention, cardiac, other issues with carfilzomib, to consider lowering the dose or giving it less frequently, I think is the key. This becomes even more important when if we use these drugs as maintenance, where again, quality of life is of high premium. So you don't want somebody to develop severe neuropathy as part of using bortezomib for maintenance. So to keep that in mind as you think about how frequent they give bortezomib, how much dose to give, and for how long.
Melissa?
Yeah, no, I agree. I follow AJ's practice, but I just want to comment also that it's important to consider both the Revlimid and the dexamethasone. You know, probably for younger patients, Revlimid 25 is okay, but frequently for patients that are more frail, over 70, 25 is too much, and we have to start even at a reduced dose. And the same thing with the dexamethasone, right? Dexamethasone patients don't necessarily have to take the 40 or will tolerate the 40 milligrams once a week or twice a week. So those for older patients, I adjust. I start usually at 20, or even a younger patient that is having some toxicity from it.
And last but not least, Prashant?
So I would agree with everything that's been said about bortezomib, about carfilzomib, changing bortezomib to once every week. Outside of acute renal failure, where time is of essence in bringing down the myeloma burden, I have never used bortezomib on a twice weekly schedule outside of a clinical trial in the past decade. In terms of carfilzomib as well, I only go with a weekly dosing. In terms of lenalidomide, in elderly patient population, as has been already said by Melissa, it's very, very important to reduce the dose of lenalidomide. Dexamethasone is the only drug that I completely discontinue after 9 cycles or so. Whether it should be 9 or 12 or 6 is anybody's guess, but based on the data that is available from the Italian study, I've stuck to 9. I do continue bortezomib up to a year, and sometimes in high-risk patients beyond a year as well. And that is based off Ajay's data, as well as the data from the SWOG 1211 trial, which has shown that after 8 cycles, you can actually de-escalate from once a week to every other week. And those patients in the SWOG 1211 trial, which was exclusively for the high-risk patients and compared VRD to VRD plus elotuzumab, showed that after de-escalation, that regimen is quite efficacious, and the rates of peripheral neuropathy, especially grade 3 and 4 peripheral neuropathy, declines substantially. So I think there's good data in clinical practice that bortezomib can be given on long-term basis. However, that is for a very select patient population, such as the high-risk group.
Now I'm going to ask each of you to go around and give us one thing that you would like the community physicians to know about frontline therapy for multiple myeloma.
So highlighting what's been discussed, I think, especially for high-risk patients, we've heard that standard approaches are probably inadequate, but the best we have currently is getting those patients to transplant if eligible, and then multi-agent maintenance, which we can help to select as myeloma specialists.
Ajay?
So I think the recent data has made it more simpler for everyone. Everybody receives a quadruplet unless there is a contraindication. So then high-risk patients should get a transplant and combination maintenance continuously. Standard risk patients, there is an option for different transplant, which I would not recommend, but my goal would be to go forward for a transplant. And there's an option for us to use MRD guidance among the standard risk patients to stop off therapy eventually.
Thank you. Shyam?
Let's say, just to add, I guess one of the things we've alluded to is that, but just to clarify, is the doses that are used in clinical trials do not necessarily translate to what we use in practice. So for instance, twice weekly bortezomib is not something we do very commonly. So just to be aware, it's unfortunate that that's the way trials are designed for various logistic and registrational reasons. But I think it's important to realize that we do use drugs a little bit differently. Once weekly bortezomib is probably the standard, at least in my opinion. It's okay to lower the dose of lenalidomide in older adults, for instance. So it's okay to start lowering the dose of dexamethasone more quickly than the trials might do based on patient tolerance, et cetera. So just understanding that there's slight nuances and variation from what the trials do. And those kinds of variations allow us to give things like quadruplets to more patients and when appropriate. So I think I would rather do these treatments with slight adjustments than to not give these drugs at all. So I think that's just a general rule of thumb for many myeloma regimens, in my opinion.
Melissa? Thank you.
Yeah, I think the key takeaway would be, yes, every patient, newly diagnosed patient, should get a DARA-containing regimen, preferably a quadruplet if they can tolerate, and if they cannot tolerate, because they're older, they're frail, then DRD, but following the response very closely. And the other thing I want to point out, two more things, is that you heard about how important is the risk stratification and also the response MRD. So very important that when you see a newly diagnosed patient and you do that bone marrow initially, that you do cytogenetics and FISH to determine the risk, and also clonoSEQ ID, so that we're able to follow that MRD status and that along the way.
We'll talk about MRD in our last section. Thank you for bringing that up. So before we conclude this section, Prashant?
So I have just one more point to add for the community physicians, that all of the information that we are giving here is just a distillation and extrapolation and interpretation of that data as we see those data. I would urge community physicians to refer patients at least once to a myeloma center to be seen by an expert, because as has already been pointed out by my colleagues here, that there are a lot of nuances to treatment, and it is best to have these patients be seen by an expert at least once.
There's a lot to think about our patients. Thank you all for sharing that insight. Next, we will look towards the future as we explore how things may change and how new data accrues. Don't miss our next chapter. Thank you very much.